So I've been given the job of talking about new MASLD guidelines in type 2 diabetes. What should Indian clinicians actually do? So these are my disclosures. So I'll begin with a case. 47-year-old male from Punjabi family in Delhi. Uh, he's an automobile accessories shop owner. He has a sedentary lifestyle. He sits in his shop from 9 a.m. to 9 p.m. No time for exercise. Consumes mainly vegetarian diet, non-alcoholic, and he presents to a hospital with complaints of fatigue for 3 months and pain abdomen mainly in right side for 1 month. He has been a diabetic for 6 years on glimepiride and metformin, hypertension for about 1 year, and on examination there's hepatomegaly. His BMI is about 33, and these are his lab parameters. As you can see on the red ones, that AST, ALT are slightly high on the higher side. Uric acid is high. HbA1c is 7.2. Grade 3 fatty liver. So the diagnosis is type 2 diabetes, hypertension, fatty liver, obesity, hyperuricemia. So what next? How do we manage such patients? How do we manage the liver part in this metabolic? So the key questions which are raised by this case: what should we do next? Is ultrasound, which was done in this patient, is it enough? Should we screen for liver fibrosis? How aggressively should we intervene? Does diabetes drug choice also matters when there is liver disease involved? And when a diabetologist should refer to a gastroenterologist for management of liver part? So there have been many guidelines on management of type 2 diabetes, many guidelines on management of MASLD, but recently in India, we have had the first MASLD guidelines mainly dedicated for patients who have diabetes. So this was led by Dr. Anup Mishra, and I was part of this. It was based on a rigorous Delphi methodology, and the consensus guideline, which was published in Diabetes and Metabolic Syndrome, that journal, it gives guidance for screening for MASLD in diabetes. How do we assess for liver fibrosis? How do we evaluate? What are the goals, dietary recommendation, exercise, and drug therapy? So I'll come to this briefly and all these aspects. So how frequent is MASLD in type 2 diabetes? We all know that it is approximately about 60 to 70% of diabetic patients do have MASLD. They have obesity, they have MASLD, and they have other comorbidities associated. So I'll go over the consensus statements which were developed in our MASLD guidelines, and this was the first one. All patients with type 2 diabetes should be screened for MASLD. So the screening could be by ultrasound, or it could be by any imaging method where you detect hepatic steatosis. That means fat in the liver. So now once you detect steatosis, does it really matter? Why should we care about MASLD? Because even if there's simple steatosis, even if there's no inflammation, there's no fibrosis, still these patients are at increased risk of cardiovascular mortality. We all know that. So diabetic patients with MASLD is an indicator that they are likely to have long-term outcomes of cardiovascular morbidity and mortality. But if they, in addition to simple steatosis, fat, if they also have inflammation, if they also have fibrosis, then they are likely to go into cirrhosis, and then this increases liver mortality also. So fat in the liver is a harbinger of both cardiovascular mortality as well as the liver mortality. So the second consensus statement, which was from our guidelines, was that all patients with MASLD in type 2 diabetes should also have assessment for their anthropometric status, their waist circumference, waist height ratio, and we also should focus on signs of insulin resistance like acanthosis nigricans, because this indicates severe liver disease. But screening for MASLD is not enough. Recently, we did a study where we enrolled about 10,000 patients across India and did their fibroscan. And what we found that these patients were asymptomatic for liver disease. They were just diabetic and they were visiting their diabetologist or endocrinologist. and we asked them to do their fibroscan. We found that about 14% of patients already have a fibroscan values which are above 10. That means they have significant fibrosis. And about 5% already have cirrhotic values, and about 3% have clinically significant portal hypertension. That means they have advanced cirrhosis. So the next statement from our consensus guideline is that type 2 uh, diabetes patients with MASLD and high risk features, for example, if they have metabolic syndrome, obesity, abdominal obesity, or poor glycemic control or dyslipidemia, they should be screened for fibrosis and using any of the non-invasive tool. We are not saying to do liver biopsy, but at least use any of the non-invasive tool. For example, you can do FIB4, which is all available in your mobile phone, or you can if the FIB4 gives an intermediate values, or if the patient can afford, then fibroscan is the best test to do this. And why should we care of liver fibrosis? As I told you, if the patient has liver fibrosis, then it increases all-cause mortality as well as liver mortality. So both these are increased. And once you have screened for fibrosis, if there's no significant fibrosis, if the LSM values are below 8, then you can possibly repeat it after maybe 1 year or 2 year. But if there is significant fibrosis, it has to be repeated depending on the level of fibrosis. So this has to be repeated depending on the. So if the fibroscan values are above 15, these patients are probably having cirrhosis, and these patients need to be referred to a gastroenterologist. But in the intermediate values, we need to give some of the therapies. And if the values are below 8, then we can repeat it after 1 to 3 years. So how should we evaluate these patients? We should also look at their muscle mass, because many of these patients have sarcopenic obesity. They are obese, but they are sarcopenic as well. And liver fibrosis and sarcopenia go hand in hand. So if you have more liver fibrosis, you are likely to have more sarcopenia, and this is vice versa. So all people with MASLD and type 2 diabetes should be evaluated for sarcopenia, because it's an independent risk factor for MASLD progression for advanced fibrosis. So you can use simple hand grip strength, or you can use DEXA scan, or even body composition analysis, which is done by bioimpedance, can be done. Now coming to treatment. So one of the most important treatment is weight reduction, because it has been shown that weight loss would actually improve not only diabetes, not only other parameters, but liver steatosis, steatohepatitis, and fibrosis. So weight loss is critical therapeutic goal for patients with MASLD. Now people would ask how much weight to reduce. So many of the studies have done that if you are able to reduce weight by 3%, then you'll improve your steatosis. If you are able to reduce weight by more than 5%, then even inflammation goes away. But if you are able to reduce weight by 10%, then some of these patients, even fibrosis can regress. So people with MASLD, so depending on their fibroscan values, we can guide them. So if there's only simple steatosis, we can at least ask them to reduce 5% weight. If there's MASH or significant inflammation, we have to ask them 7%. But 10% is what we should try and aim for all of these patients, because it will not only correct all the above factors, but also reverse fibrosis in many of these. And weight loss strategies should be combination of hypocaloric diet plus physical activity. And then should give a trial of these lifestyle measures. But if the patient is unable to achieve adequate weight loss, then obviously these patients would merit some pharmacological therapy, or if that also fails, then bariatric procedures, either endoscopically or through surgery. So some statements regarding weight, regarding diet. So we have to reduce refined carbohydrates. We have to reduce ultra processed food. Macronutrient content we advise is about 50 to 60% of carbohydrate, preferably complex carbohydrate, 20 to 30% fat, 15 to 20% in protein. We should limit saturated and trans fat, and advise MUFA and PUFA in these patients. Minimize fructose intake and sucrose intake. Non-nutritive sweeteners, we have to be very cautious because their long-term metabolic effects are still uncertain. Coffee consumption has been shown to improve liver fibrosis as well as liver steatosis. And intermittent fasting or time restricted eating may help, but we have to be cautious because these patients are diabetic. So, which patients to advise needs to be individualized. And complete alcohol abstinence. No amount of alcohol is safe for a patient of MASLD diabetes. So then often people ask, patient ask, which food to avoid, kya khaएं, kya na khaएं. So this consensus document actually gives a list, entire list, what to eat, what to avoid. So I would request you to go through all the paper itself for all these details. Regarding physical activity actually improves insulin sensitivity, reduces inflammation, benefits steatosis. So best is to combine.
Sir, please conclude.
Yeah, in 2 minutes. Both aerobic and resistance training. And target is about 150 to 200, 300 minutes per week of moderate intensity. Or if the patient is able to go for vigorous activity, then 75 minutes plus resistance activities. And we should encourage NEAT or non-exercise activity thermogenesis. That means increasing physical activity, basically. For pharmacotherapy, I'll just give a brief algorithm. So you do a fibroscan or you do FIB4, and depending on the patients, like all these patients are diabetic. So if they have significant fibrosis, you have to give those drugs which have got good data on fibrosis reduction. So for example, semaglutide is there, resmetirom is there, and even emerging data on tirzepatide is coming, or SGLT2 inhibitors. So I'll not go into details of these. I'll just summarize, come to my last slide here. So my take-home points: MASLD is the rule, not exception in type 2 diabetes. Most patients have it. Fibrosis stage actually drives the prognosis. Lifestyle modification is the foundational treatment modality. And after that, we need to use those drugs which also take care of diabetes as well as liver-directed therapies. And GLP-1 agonists have been shown to be beneficial, especially semaglutide. The trial results are there. And the treatment has to be individualized, and we have to, it has to be maintained. It cannot be just for a short period of time. Thank you for it.
Thank you.